we're talking about interesting stuff that we never really were able to get at before.
Well, I think that's what's fascinating is, and in my opinion, I'm curious if colleagues says, I actually think that there probably was never very good data that we ever needed to do these trials to begin with. But thank God we did.
Let's be very specific. Which trials? The cardiovascular
Well,
risk?
I think that there was this signal for the
Cardiovascular
TZDs that turned out not to be true. And it's certainly a huge amount of machinery, the FDA, and billions of dollars to do cardiovascular outcome safety trials. I'm not sure that that needed to be done, but it ended up being a great sort of boon for these patients because we now are talking about drugs that may be beneficial. We would have never had that data had the FDA not required it.
I agree with you, but think about the FDA doesn't approve statins just because they lower LDL. Why are we approving other classes on surrogate markers when we have?
No, it's a valid point.
Well, we do have these little worrisome things, right, in the IRIS study. You mentioned weight gain, heart failure, bladder cancer, some edema.
And fractures.
And fractures.
And I think the big thing is the edema and heart failure because we know that diabetics up to 50% could at some point develop heart failure. And so, there's a big chunk of the diabetic population that TZDs are never going to be an appropriate therapy for.
This is off topic, but I do think that's going to be a really big thing in the future. There seems to be some kind of microvascular myocardial dysfunction, so they have really stiff hearts, really prone to heart failure.
So who's the appropriate population for a TZD, and what populations should you avoid TZDs? Anybody want to try this?
I think we already alluded to the ones that we would avoid it. Your individuals with congestive heart failure or...
most of our patients.
Yeah, most of our patients.
But not most of ours. I mean, I think the thing is that it is generic and it's effective. So I think as part of the oral armamentarium, they can have an important role.
Yeah, I do think also elderly patients who are already at risk for fractures, this probably is a drug I would think more carefully about if I could use another agent.
I don't want to leave this topic without talking about DPP-4 inhibitors, cardiovascular safety. Christian, can you lead us down that road?
Yeah, so there are 3 DPP-4 inhibitors. They've all been studied in large cardiovascular trials. We have saxagliptin, alogliptin, and sitagliptin. And the drugs, unlike the GLP-1 receptor agonists and the SGLT2, there doesn't appear to be a cardiovascular benefit to these drugs. And for the most part, these drugs are also very safe from a cardiovascular signal. There was one trial, the SAVOR-TIMI 53 study, with one of the drugs that seemed to show there was an increased risk of heart failure. Now, this was in patients who were at risk for developing heart failure. They either had heart failure at baseline or they had elevated markers or bad kidney function. For the other 2 drugs, one of them looked like there was no signal, and there was a retrospective study for alogliptin that said that there may have been in patients who were in heart failure when the study was enrolled. So I do think the drugs are pretty clean from a cardiovascular perspective. There is some data that one of the drugs is associated with heart failure, though not heart failure-related deaths. But for the most part, I think a pretty clean cardiovascular
There's
signal.
boxed warnings on 2 of the drugs.
Correct.
Right, but I do think the data for alogliptin is a post hoc analysis, and only in patients who showed up with heart failure.
So are the DPP-4 inhibitors going to slowly be relegated to...
I don't think for a safety perspective, but I think for the fact that you have other cardiovascular drugs that have a overwhelming benefit.
I think there's a new bar.
Right. Right.
Well,
honestly,
there's a new sheriff in town, right?
Because the patient that would be the ideal candidate for a DPP-4 inhibitor will probably be also for a GLP-1, right? So you other than the injection part of this, you would gravitate towards the incretin therapy that gives you the cardiovascular benefit.
And I think to Stephen's point, like maybe you'd use a TZD because of the efficacy on the glucose side, where the DPP-4s don't give you any benefit for the glycemia.
The issue is that they're simpler to use, and I think that's why people use it. It still shocks me that what a few percentage of people are using GLP-1 agonists, where you get much more bang for the buck, if you will, in terms of all of these benefits. But it's very easy to, as either add-on therapy to add a DPP-4, even though, as you mentioned, you don't get the efficacy.
Yeah, and injections are barriers to a lot of
Right.
patients.
Well, but let me...
Not
let
to
me-
patients, it's actually more of a problem for us as clinicians.
I was
Because
gonna ask about
patients
that.
if you tell patients, particularly if you say, and you will lose weight, they'll inject themselves in the eye. You know, so it's a question of, I think we think it's a barrier, and I think we also, just because it takes a bit longer to explain how to use it, but they're safe, they're effective. You know, it's shocking that they're not used more frequently.
What is the typical reaction in your office? You say to a patient, look, there's this great drug, we've got this new data, it's 50% better in many ways, but you're going to have an injection either daily or weekly or monthly or whatever. What do they say?
Well, I think if you say, but you're going to have an injection, I'm already putting a negative on it.
Right,
Okay, fair enough. So how do you phrase
So
it?
what I do is I say, frankly, this is, it's a tiny needle, and I'll inject myself in the office, and I'll try not to cry, and then I will inject them in the office, but I'll do is ask them to close their eye and tell me which arm they're being injected in, and I'll pinch one arm and I'll inject the other, and the vast majority can't even tell. So I think once they see that it's not that
Right.
big a deal, it's much easier to progress.
But the GLP-1 do have some GI issues as well, right? There are some.
Right.
But
But it subsides over time for the vast majority, and it's a little bit different depending on whether you're using a short-acting versus a long-acting agent. But again, all these things are part of the education, and I think more than anything from a patient's point of view is more the injection issue, and you have to meet them where they are. Their concept of what the injection can be, it may not be your 6 millimeter needle. It might be they're thinking about this needle that is
And
going
they
to cause insane pain.
And
So-
the issue of the GI is frankly also it may even help your lifestyle, because I tell people eat half what you'd normally eat, because a lot of the feeling of GI distress is actually a feeling of fullness, which is one of the
Satiety, yeah.
benefits of the
Exactly.
GLP-1s.
I've said that a million times. I think that's part of the benefit of why they lose weight. You feel full. And so,
Tell me a little bit about just the pragmatic use of these drugs. Storage, do they have to be refrigerated? Do you pick them up once a week? Do you, in terms of the patients dealing with this day by day?
Well, there's different, liraglutide is, you can use, that's available for 6 weeks without being refrigerated. You have the exenatide is really kind of is good for 4 weeks. The problem is that now we have once monthly injections that make it sort of much easier. And even one of the agents, you can't even see the needle. So basically, you inject the person. It's so intuitive that it makes it much easier. And it really depends, frankly, on what's covered, as well as kind of working into the patient's lifestyle. But really, I don't see it as a barrier. Frankly, I see it's very easy, and particularly as you mentioned. If you mention, and by the way, you may actually get your blood pressure decrease, and you may actually lose weight. That's it, done. Let's do it.
I mean, this is ridiculously good. What am I missing? Am I missing anything here? I don't think so.
well, we remember every medication has a potential adverse effect
Here it comes, I
profile.
know.
But I'm saying these look very clean, just like you said, but we can't get cavalier. We have to remember that.
And they're relatively shorter, like all clinical trials, relatively shorter duration. So I do think, it's important to say when you roll these out broadly into the community and we look at people who've been using these drugs 10 years, 15 years, there are sometimes signals that emerge that were unanticipated from the trial.
And there's a new agent actually that is actually even beyond, quote, the injection. It's where you actually have an implantable system that can last for 6 months, and it holds blood sugars very stable. That will be coming out in the future, and that overcomes a lot of the issues.